This is WCNY's The Capitol Press Room, and we're joined remotely by Lauri Cole, Executive Director of the New York State Council for Community Behavioral Healthcare, whose members provide a range of recovery and treatment services for New Yorkers dealing with mental health and/or substance abuse conditions. Welcome back to the show, Lauri.
Thank you, David. Good to see you.
Good to see you. Well, I want to start with a comment you made during your budget testimony about the flow of dollars the state intends to send your 165 member organizations. You said in some cases it's taking years for funding to reach providers. What dollars were you referring to, and what is the problem in the state's process that needs to be addressed?
Well, the budget testimony that I provided talked about lots of different ways in which reimbursement is delayed or denied to care providers who are generally very fragile fiscally and hang on those payments to be on time and in full. And in fact, there are state laws that require it. However, what I focused on during testimony was the COLAs, the targeted inflationary increases, as we're calling them now, that this governor has and the legislature has enacted over the last, let's say, 3 and hopefully 4 years, and calling attention to the fact that those dollars that presumably are enacted on or around April 1st don't reach providers for months and sometimes years due to a range of issues, but primarily insurer tactics that delay payment. Um, so what happens is the state will enact a rate increase, and the state goes through its own gyrations of having to make that public, put it up online so the plans are informed, etc. But at the end of the day, if plans are not paying the right rate, or if their technology is not scheduled to conform to rate increases, or they just feel like waiting, they do. And so my goal was to let lawmakers know that the intent of their work to deliver these meaningful, very important increases are not getting to providers on time and in full. And in some cases, that is years.
Well, that experience leads me to another issue the governor has raised, and that's this idea of trying to identify rules and red tape that might be hindering the administration of government or the achievement of the government's goals in a timely fashion. Do you have any suggestions for the governor, either as it pertains to bureaucratic government red tape, so to speak, or maybe some of the players that you interact with, like those insurance companies?
Well, understand that in the fall of this year, the state agencies that we relate to, the Office of Mental Health and OASIS, asked the associations that represent providers for suggestions around administrative and regulatory reform. And so we went through a process with them of providing that information. And at the top of both lists for us was the carve out. We are requesting a carve out of most mental health and substance abuse services from the state's Medicaid managed care program. Not only would that save $400 million for the state that could be reinvested into things like workforce shortages and other necessities, but also the carve out um, will relieve providers of the myriad of different requirements that each of the insurers that they deal with require of them.
You're talking about the system that was put in place as the state moved away from a traditional fee-for-service
Yes.
model and began making the insurers play a larger role in terms of what was supposed to be about the coordination of high-quality care for those Medicaid patients. But in practice, critics argue that it has not realized any of those goals.
Right. The 10-year experiment has failed. 10 years ago, under the Cuomo administration, our services were put into a package called Medicaid Managed Care that hires insurers to manage services and to arrange them for their beneficiaries. And the data is compelling. It is sad, and it points to a failed experiment that needs to be reversed. And so we are looking for a carve out of our services from the state's Medicaid managed care program to return it to a more direct reimbursement process that avoids the conflict of interest that insurers currently have and exploit. in our opinion.
And you're referring to their profit motive there, as opposed to this idea that they're invested in the quality and outcome of the care. But when you talk about a carve out here, is it just a complete reversal of the system that's in place and a return to what was the norm more than a decade ago? Or is there any sort of happy medium that could be embraced? Could there be a fee for servant payment mechanism within a managed care arrangement, for example? Or are there other things about coordination of care that could be focused on if we are moving away from the Medicaid managed care? Because that was one of the concerns in the past, was this idea of, say, you couldn't have someone assigning responsibility for integrated community care based on the former model. So, what does life after Medicaid managed care for the behavioral health care system look like?
So, for the majority of services that are under the OASIS and OMH umbrellas, the two state agencies that I spoke of earlier, those services would be moved out of the Medicaid managed care program and away from insurers' direct control. Right now, insurers are managing cost, they are not managing care. And the conflict of interest that I mentioned is the fact that the state pays the insurer in advance of a quarter of business, a per member per month fee based on the number of enrolled Medicaid lives that that plan covers. And then for health plans, the idea is to hang on to the money as long as possible and put it in the bank, make interest on it. So, in addition to the state paying these vendors $400 million dollars a year total every year for serving in this way, the real money is the ability for the plans to manage when they pay, when they don't pay. And frankly, the appetite for aggressive enforcement in New York State does not exist. In the budget hearing, I talked about surveillance, monitoring, and enforcement of the laws, the regulations, and the contract provisions that are attendant to Medicaid managed care being of the utmost importance. If you don't have a fearless regulator that is willing to say, no, health plan, you did the wrong thing. We're going to send you a message that says you can't continue to do this. If you don't have that, then you have a free for all and you have windfalls for health plans. But back to your question, what does it look like? It could look like an intermediary, one intermediary managing care. It could look like a simple return of the reimbursement process to a provider and the state. So a direct line between the two, where the insurer is pulled out of that triangle. There are many ways to structure it, but at the base of it, you're removing the middlemen. You're removing those that have a clear conflict of interest. And you're saying what we care about is people, not profit. What we care about is access to care, not access to care when the insurer is good and ready to make it available. And you can see that, you can see the numerous tactics insurers use to methodically sort of delay payment and care in the Ghost Network study that we've talked about in the past. You can see it in a million different ways, and the data is replete. One of the statistics that I like to talk about that is astounding to me, David, is that in instances where a person with a substance use disorder and Medicaid managed care insurance appeals an insurer decision that denied care, if you're a New Yorker and you have the gumption to move through the appeals process to the end, it eventually gets to an independent medical examiner. And in those cases, the insurer is overruled 64% of the time. That means the decision the insurer made to delay or deny care to the insured is overruled by an outside arbiter.
Yeah, you brought that up during your budget testimony, and I was curious how much we should read into that, because from the way you frame it, it makes it sound like that outside arbiter is the end all be all. They know right from wrong, but do they really have any skin in the game? Are they just basically motivated by anything? Are they focused on best outcomes? Because it seems to me if they are not tied to anything, maybe their default will be, sure, pay this, or sure, run this test. Why not? No skin off my back.
To be honest with you, I don't know exactly the type of job description of the medical professionals that review these appeals. This is the last stop on the continuum.
Mhm.
So presumably the client has gone through the rigmarole of previous appeals where they have been, where the decision has been different. And so you have someone electing to assert their rights and to try and get care. I mean, that's what this is about. If 64% of the time it's overruled, that doesn't mean that it's 100% that are overruled. And so it looks to me like a process that reflects what I'm talking about here in terms of the decisions that insurers make being more motivated by profit and their own need than it is for New Yorkers, for people who have this insurance.
Well, we've got about 2 minutes left, and I want to come back to what you were bringing up with regards to enforcement. And during the budget testimony, a GOP assembly member highlighted the idea of Texas allowing for insurers to face $1 million fine for failure to timely pay claims. And that made me wonder, is New York's enforcement strategy a product of the tools and levers that they can pull, or do they have resources and authority that they're just not utilizing?
I think that the Department of Health, in the case of Medicaid, would say that they have contracts with plans that have a lot of rights um, that health plans have in this process when they are found to not be following the law, not complying with the law. Um, But at the end of the day, what we have found, what providers that I represent have found, is that the process by which you complain to the Department of Health is long. It is laborious. It is designed um, to give pause to the provider in terms of the resources that are necessary to file a complaint. It deters providers from doing so. Having said that, complaints have resulted in over 320 citations to this point. Um, but at the end of the day, it's a long process. It's an arduous process. Providers don't have the resources to always complain. And there is a lack of staffing and resources at the regulator.
Well, is that laborious complaint process one of those areas of red tape that could be cut?
It could be. In conversations that I've had with state leaders, they continue consistently say that the process is not broken. And then I hand them reams of paper that shows that it is, and the expectations on the provider for providing the amount of information required to even start a complaint. So, yes, that's a great idea. And to your original question, David, our recommendations for administrative and regulatory reform begin and end with a carve out. You can save money for the state, and you can also cut the red tape that binds providers and that creates delays in access to care for New Yorkers.
Well, we've been speaking with Lauri Cole. She's the executive director of the New York State Council for Community Behavioral Healthcare. Lauri, thanks as always.
David, thank you.
And for more Capital Press Room content, visit capitalpressroom.org or wherever you download your favorite podcasts.